Hi, everybody. How are you? Good evening. And thank you for taking time out of your day to join us this evening. My name is Brenda Moynihan, and I am the Director of Marketing and Outreach here at the Kensington Assisted Living Residence. And I am honored to welcome you this evening. Tonight's presentation is Management Strategies for those with behavioral and psychological symptoms of dementia. During today's presentation, we will learn how these symptoms present, ways to manage, and case studies to learn what did and did not work. Before I introduce our speakers, I'd like to briefly give you some information about the Kensington. The Kensington is an enhanced assisted living, and we're located in White Plains, New York. We have a full spectrum of clinical support, including caring for those with Alzheimer's and additional dementias, those with moderate to very high care needs. If you would like some information about our senior living community, please feel free to call us at 914-390-0080 or go to our website at www.thekensingtonwhiteplains.com. And now, please join me in welcoming our speakers for this evening, Donna Sanji Valerio and Dr. Karen Bell. Unfortunately, our third speaker, Dot Tagarelli, could not make it this evening. Dr. Karen Bell is a neurologist and professor of neurology at Columbia University Medical Center in the Taub Institute for Research on Alzheimer's Disease and the Aging Brain and the G.F. Sergevsky Center. Dr. Bell graduated from New York University and the University of Pennsylvania School of Medicine, where she completed internship in internal medicine at Harlem Hospital Center and neurology residency at the Neurological Institute at Columbia University, College of Physicians and Surgeons. After completing a fellowship in behavioral neurology, she focused her clinical and research efforts to specialize on the evaluation and treatment of neurodegenerative cognitive disorders at the Taub Institute. As the director of the education core of the Alzheimer's Disease Research Center at Columbia University, she's developed physician and community education programs. Dr. Bell was appointed to the New York State Council on Graduate Medical Education by Governor Patterson in 2009 and chairs the New York State Cogni Empire Clinical Research Investigator Program Workshop. Welcome, Dr. Bell. Donna Sanji Valerio. Donna is a dementia coach at Dot Cares, a geriatric care management company. Her passion is to effect change in the manner care is delivered. Donna has held positions as a memory care director at an area assisted living, plus director of adult daycare centers. As a dementia coach, she shares her expertise in effective caregiving practices for people diagnosed with dementia, and one that recognizes and gives considerable attention to the needs of the caregiver. Welcome, Donna. So speakers, I'm going to ask you ladies to please join us. Dr. Bell, yay. Yay, here's my speakers. And Donna and Dr. Bell, before we get started, before we get into the meat of the presentation, Dr. Bell, can you talk to the audience about the different types of dementia, some types, some common types, and how they present?
Yes, I want to thank Brenda and the Kensington for inviting me to participate in this program. Everyone knows what Alzheimer's disease is or knows somebody who has Alzheimer's disease. So that's the most common type of dementia. And, you know, that's the one where the symptoms are typically trouble with memory at the beginning, and then word finding difficulty, and then eventually starting to have trouble with other brain functions like thinking and perception, visual spatial function, those things are affected as well in the illness. And then as it progresses, because remember, this is a slowly progressive condition. As it progresses, you begin to have difficulty with activities of daily living, managing your checkbook, if people still have checkbooks.
I do.
And,
Point.
and then eventually, as it progresses to the more severe stage, you have difficulty with basic activities of daily living, like toileting, bathing, grooming, dressing, and you need help. But Alzheimer's disease is not the only dementia. It's the one that's the most common and the one that people are most familiar with, but I want to touch on a couple others. Vascular dementia is another type of dementia, and this occurs in people who've had silent strokes or small strokes or the so-called mini strokes, which there's really no such thing. And those type of events can cause, if you have enough of them, can cause you to have a stepwise decline in your cognitive function. So unlike someone who has Alzheimer's disease, in which it slowly gets worse over time, people who have vascular dementia can, every time they have a little event, can have a step down and then go on a plateau and then have another cognitive step down and go again on a plateau. And the symptoms, while it can affect memory, some of the symptoms that you would see with that condition are maybe slowing and decreased attention. You can see subtle changes in mood, like depression and apathy, or being less interested in things. So it looks different than Alzheimer's disease in general. And if you prevent additional silent strokes from happening or small strokes from happening, then you don't decline in the same way as someone who has Alzheimer's disease. Another type of dementia that is almost as common as vascular dementia is dementia with Lewy bodies, or Lewy body disease, DLB, goes by a lot of different names. And that type of dementia looks different from Alzheimer's disease because these are people who begin with visual illusions or visual hallucinations. Sometimes one of the earliest symptoms you might see with Lewy body is difficulty parking because they have visual spatial problems. So you know how
Interesting.
in the city you have to parallel park. That involves a lot of function, and that's one of the first things to have a problem with. If there are visual hallucinations, they're not like the type that people who have schizophrenia have. These are fully formed, stereotypical visual hallucinations where you see the same thing all the time. You might see animals around the ceiling, or if you go into a room and there's a sofa with a pattern, you might see somebody sitting there, but when you go closer to them or reach out to touch them, they disappear. And it's a very similar visual hallucination each time. And early in the course of that, people know it's not real. But as the disease progresses, they become less aware that those visual hallucinations are not real. You can also have slowing with Lewy body disease. And then there are these fluctuations in level of alertness as the disease progresses, where people with them may think, oh my gosh, they passed out, even though they're sitting up. They're not there, they're unconscious. But you know, if you wait a few minutes, they come back to themselves. It's a fluctuation in level of alertness. So that's dementia with Lewy bodies. It progresses just like Alzheimer's disease does. So you get worse over time. The course may be a little shorter than Alzheimer's disease, which is longer, but it looks different. And then the last one I want to comment on is frontotemporal dementia. And frontotemporal dementia is different from Alzheimer's and Lewy body and vascular dementia. These are people who have behavioral symptoms early on in the course of the illness, and memory is less likely to be affected early in the illness. So these are people who might be disinhibited, not as well dressed, but not noticing they're not well dressed. Their judgment is impaired. They may be more impulsive. They may say hurtful things to others right at the beginning of the illness. That can happen in the other diseases later in the course, but this is at the beginning. They can also have changes in speech where they can repeat the same thing over and over, but they're stock phrases. They can repeat what you say to them, or they might even have reduced speech. These are people who also, their food preferences may change. They may try to put everything in their mouth. So frontotemporal dementia early in the course looks very different from Alzheimer's disease or the other dementias that I described. And when people go to the doctor and get diagnosed, they shouldn't be diagnosed with dementia, because dementia is an umbrella term. It does not tell you the specific disease that falls under that umbrella.
That was wonderful. That very concise. And I have to tell you, parallel parking, I couldn't do it when I was 18.
Well, that's not good.
So, but yeah, that was wonderful, because I learned a couple of different things in that concise little speech you just gave. That was wonderful. So now that you've given that overview and the audience heard that, let's get right into what are the behavioral symptoms that some people may be experiencing right now with their loved ones at home. What are they and how do they present?
All right, so there are a lot of behavioral symptoms that can happen. Some people will call them behavioral symptoms, some people will call them non-cognitive symptoms. They are often the thing that brings someone to the doctor, or makes their caregiver or family member bring them to the doctor, because people are very forgiving about memory problems. But when things start to go wild at home, that is when they want some kind of intervention. So I think this is a very timely program to give people some tips about how to handle some of these symptoms. So one of the things that can happen to people is they become apathetic. You may notice that someone is less interested in participating in activities or their hobbies, things that they used to do. They just want to sit around and do nothing. Watching TV is the same as doing nothing. They want to not go out of the house, become housebound, but not because there's any illness that's keeping them from going out. They're just less interested in things. They're also less interested in conversation. So apathy is something that you can see in any one of the dementias that I mentioned. Other behavioral symptoms that can appear are mood disorders. Now, along with apathy, you can see depression. The depression initially may present as apathy, but then you start to notice they have other symptoms of depression. They're not eating, they're starting to lose weight, they're less interested in talking to family members. They don't want to, for example, the phone conversation lasts 1 second instead of 20 minutes. That will be the kind of thing that you might notice if they're depressed. Along with depression, you can have anxiety. Some people develop anxiety and they are nervous about not just going out, but nervous about everything that can happen. Typically, a doctor's appointment is coming up, and that can cause a lot of anxiety. What's going to happen to me there? I don't think I want to go to that appointment. Very typical. Other behavioral symptoms are things like restlessness, agitation, aggression, and that's a spectrum. When you get to those type of symptoms, maybe the mildest part of it would be if they're just restless. So these might be people who are pacing, can't sit down or can't sit down for a very long time. The restlessness can manifest as, you go to a wedding, they're perfectly well enough to go to the wedding and participate in the wedding festivities, but as soon as they get there, they're ready to go home. This is one of the most maddening symptoms that caregivers have to deal with. You got dressed up, you went all the way to the event, and they're ready to leave 10, 15 minutes after you got there. That's restlessness. That restlessness can escalate as time goes by and include agitation. So instead of just not wanting to stay there, then you're you're getting upset and angry and maybe calling out or saying mean things because you want to leave. So they can get agitated, and agitation can occur at any time. Agitation can get worse and turn to aggression. People will want to fight and push you or hurt you or give you an equal force for whatever you're trying to get them to do. And that would be the aggression. So it's a range that you get with restlessness, agitation, and aggression. There's this term of sundowning, which is not really it. What it is agitation that can happen in the late afternoon, early evening. So that's why it's called sundowning. But sundowning is also part of the sleep-wake cycle disturbance, because people become more confused, a little more disoriented. That is what happens to you. You're a little more confused as the day goes by. You're probably at your best in the morning. And when you develop sundowning, it's likely to happen every single day around the same time. And caregivers need to know how to deal with that. And since I'm talking about the evening now, let's get to sleep disturbance. People with these disorders don't sleep the same way they did before they developed the condition. The sleeping problem can be as simple as having trouble falling asleep or waking up in the middle of the night or waking up extra early. But it can also involve excessive daytime sleepiness, sleeping all day and not sleeping at night. And there is a disturbance of the sleep-wake cycle. So we definitely have to address that and always talk about sleep so that it can be managed. And then there are delusions, which kind of go, so suspicion and delusions kind of go together. And you can have that with agitation, but people can start off when they're in the mild stage, just being a little more suspicious. You know, when things go missing, if you misplace something in your house and you can't find it, you immediately say someone stole it.
Right.
So that would be the suspicion, and then the paranoid delusion that someone is coming in and taking your things when really they're just, you know, it's over there, it's a little misplaced. So that is also another common symptom that people have trouble with. I think I covered everything.
It's very interesting. I mean, you know, Dawn and I have talked about this before, where if you've met one person with dementia, you've met one person with dementia. So all of those different things, Dr. Bell, that you're talking about, someone may have 2 out of the 10, someone may have 9 out of the 10. So it really varies with the person. Is that right?
That is true. You can't predict what is going to happen. Somebody who's the mildest mannered person for decades of their life could become someone who is aggressive and agitated and saying things that you would never have thought coming out of their lips. Somebody who was, you know, quite the tough person, always, you know, shaking things up, becomes more docile. So you can't predict how someone is going to be, and no one person with these diseases is the same as anyone else. And I always try to tell people that just because you know someone with this illness doesn't mean that your parent or your sibling is going to be that way.
Right. Great. Right. Donna, you know, going off of what Dr. Bell just mentioned, in your experiences, what are some of the triggers that you see? And can you talk about some case scenarios?
Okay. Well, Dr. Bell, I did learn some things today, so thank you very much. And Brenda, thank you for this opportunity. I do want to start off by saying that it's very easy for me to give this information out, okay? But as care partners, caregivers that I'm sure are in the audience, it's hard to hear. It's, you know, you're dealing with the loss of your spouse or your best friend or your mom, you know, in the sense that she's losing her memory, and you're becoming now the care partner, and you're focused on the loss, you're focused on the changes, and it's very difficult then to start making changes in your relationship with them. So I always like to say it's really important to kind of think about what's remaining rather than what they lost. All right. I think we want to make everything, which is very difficult, to put mom doesn't remember, how to cook her meal today, but, or make her famous apple pie, right? But she still may be able to slice the apples or just discuss the recipes, the ingredients. So it is easy for me to say this, but I know, on the other end of this is hard to hear. Everyday life is stressful no matter what, but somebody with the symptoms of dementia, it just becomes more and more difficult. And especially in their early stages and the early diagnosis, when they're aware that they are forgetting, and I always say to family members, don't underestimate how much they do understand and how much they know, all right? It's very important to assume that they understand some of what's going on around them, so you could understand what those challenging behaviors are going to be, all right? The reason why, and they're called challenging behaviors, I think it's because they're out of character. So is now putting his coffee cup, in the refrigerator, and something he never would have done, or, his dress isn't as meticulous as it used to be, that's really hard to handle. So that's why a lot of times they call it challenging behaviors when in fact it's really not, all right? And it's important to know that there's no intention for this. They're not doing this to upset their spouse. They're not doing it to tick you off, all right? This is just part of the disease process. The brain is just not working to its potential. What the heck is it? There's no magic pill. Dr. Bell will agree. There's no magic pill for these behaviors. So what we want to try to do is understand why the behaviors are happening. So if you could understand what's happening, then maybe sometimes you could figure out, well, how could we prevent it? I always recommend to families, especially when they're newly diagnosed, is now is the time to make some of those changes to put safety mechanisms in place, all right? So now's the time to create a supportive environment for your loved one with the disease. Make life simple, make the environment simple. Now, I also say to many of the spouses, this is not the time to redecorate, all right? This is not the time to change the curtains and rearrange the kitchen. This is the time to keep everything status quo. But this is the time to maybe remove the clutter. Maybe that end table that your husband or you keep tripping over every night when you're going to watch TV. Maybe now's the time to maybe reposition or maybe remove it, especially while they're in the early stages where they can learn. They can learn if things are repetitive, things are done simply and clearly. They can learn like, oh, okay, that the coffee table's not there anymore. Always keep these, and this is the kind of these things here now are really applicable to anybody. Keep things in the same place every night. Keep your wallet, your cell phone, your other valuables in the same place every night. Now, if your husband always traditionally put them in the bowl by the door, that's not the time to change it. I always suggest carrying a mobile phone with location capability. I went on Amazon today, and it changes every day. Just go on Amazon's website and just look for the GPS tracking cell phones and GPS tracking bracelets. Very, very helpful. They work. I also work in a school, and you'd be surprised how many families are doing this with their kids, just to make sure they know where they are. I suggest starting with a calendar for you and for the person with dementia. Get them used to looking at the board in the kitchen in the morning to say, oh yes, we have a doctor's appointment today at 10 o'clock. Because that sometimes helps them ask the questions, the repetitiveness that we'll talk about. And exercise and eat healthy. I can't tell you that enough. Before we go into the behaviors, I always suggest to families, and especially if their loved one is in an assisted living at the Kensington and Brenda, I know your team in the dementia unit does this, you need to put down their life story. You need to understand what this person was, did, past, present, and what their goals were for the future, all right? It's really important, and the reason why I say this, because maybe some families are sitting there saying, well, he's at home, I know that he likes, pancakes for breakfast, that sort of thing. But as those challenging behaviors happen, we always recommend to families, now's the time to maybe start getting help in. This is their Bible. This is your spouse's Bible of what they did. And sometimes as you're writing them out, you sit there and say, oh my gosh, yeah, I forgot that, when he was in the war, this is what they called him. They called him Chief. We had a gentleman in one of the adult day programs, and his name was Chief. He spent his career in the war, And so you had to treat him as if he was still in the war. And I'll never forget, one day we were holding the umbrella as he was getting on the van. It was really raining heavily. And the next thing you know, he threw me to the floor and stood on and covered me. Now, right, the van drivers are right there. They're ready to take him off and punch him out, right? But what happened? What did he hear? This was a man that spent his whole career in the war. The sound of the raindrops on the umbrella, he thought we were in the war and he was protecting me.
Oh, wow.
Right? If you didn't know that about the gentleman, you would have reacted that, oh my goodness, he's hurting Donna. All right. So these are the things, and I always suggest to the families is have all the family members and some of their best friends help contribute to the life story, because they might know something about him that you didn't know. And those are distracting techniques when the person is having a challenging behavior. All right. There's usually 3 types of triggers. There's usually the medical, the psychological, and the environment. All right. The medical is clear cut: sickness, fever, pain, medication side effects if they've started a new medication, an earache, a toothache. And it's also important to note, and I'm sure Dr. Bell will agree, you don't get drastically bad overnight. I always tell family members, if dad was fine today and all of a sudden tomorrow he's having these big off the wall behaviors, you don't call, oh my goodness, his progression, it happened overnight. Something's going on, something physical is going on. That happens, you know, I have a wisdom teeth that just cut the skin today. It hurts, all right? I was fine yesterday, all right? And that can make me a little cranky today when I go home, right? Because I have a pain in my tooth. So if a normally happy person all of a sudden becomes miserable and cranky, it's because that there's something physical going on. And it's important to remember that I believe, no matter what stage of the disease they're in, they want to communicate, all right? They're trying to get their message. They're trying to get their needs met, right? And behaviors are a form of communication, all right? So if you just kind of look at it, and you have to play detective, like what is my husband trying to tell me in his pacing or his repetitiveness? The other thing could be environmental, all right? It's very hard for somebody with the illnesses to process everything around them. So it's almost like driving down the parkway, all right? Think about when you're driving down the parkway, doing 80 miles an hour, which I quite frequently do, but think about if you're doing it, I know I shouldn't have said that, I hope there's no police officer in the audience. You're doing 80 miles an hour, you got the top down and there's no window. Can you take in the street signs? Can you see where you're supposed to get off? All you do is it's a barrage, it's just coming at you. Most every day of their lives during this disease process. So it's our job to remove all the distractions, the environment. If today snows, if the snowplows are coming through tomorrow, make sure the windows are shut. Make sure that maybe you're doing something with him while those snow blowers, or everybody's got their snow blowers and the tractors, et cetera. Or in the summer, especially in the summer, when the windows are open and people are mowing their lawns. It's very difficult for them to understand, is it not in their backyard or is it outside? And that's sometimes when they hallucinate too, because they think there's a lawnmower in their house, or they can't make sense of what that noise really is. So you got to be aware of how they hear it. So that's why when they're acting out, I know it's not easy, but they have to just take a step back and say, okay, what just happened? You know, what was going on when my father just pushed me out of the way? Maybe he just had to go to the bathroom. All right. Certain things with the environment, maybe now's the time to make sure they know where the bathroom is. All right. Straight path to the bathroom. Sometimes with the environment, if it's the same color, and I know this is very common in bathrooms, especially when you have a bathroom that's maybe on the first floor that you use just for toileting. We have a beige wall, we have a beige toilet, and maybe the floor is a little bit beige. So now all of a sudden they're calling the doctor and saying, my husband's urinating on the floor. He can't get into the toilet. What's happening is he can't see the difference. Right. Now that's the back of the wall, a contrasting color. So then they can see the contrast. And then think about it, even for ourselves, you know, as we get older, our eyes are diminished, you know, graying, cataracts, etc. So even for somebody that can make the connection, now somebody that's confused can't figure out where the toilet is, they can't see. Same thing with maybe the checkered times they'll be bending over and they want to pick something up off the floor. But what it is the checkers on or the flowers, they're seeing things there that maybe aren't there, or they think it's time to pick it up. And now you as your wife or your husband or you, it's okay. And now he's annoyed because he wants to pick whatever's up that's bothering him. So it's really important to just kind of get in their world and try to figure out, what are they doing? What are they seeing? A new person that's just walked in. So now you're outside shoveling the snow tomorrow, dad's helping you, and all of a sudden the neighbor goes over to dad and says, Joe, how you doing? Great seeing you. And he looks and he goes, do I know you? Now, you turn around, the spouse turns around, or the daughter says, Dad, come on, we've been neighbors for 25 years. You know John, you help him mow the lawn. You've caused a challenging behavior to occur because now he's like, I don't know who this person is. And now he's upset and now he's embarrassed, all right? So that's when you turn around and you say, oh, I just love meeting new people. Hi, I'm Joe, all right? Just go with it. It's not important that he doesn't remember you that you're for 25 years. Another trigger for challenging behaviors is lack of routine. Bless you, Brenda. But I couldn't hear it. Another cause of challenging behaviors is lack of stimulation, no activity, boredom, all right? They don't know what to do with themselves. That's when the pacing begins, the wandering. What do I do? That's when the hoarding, they make their own activity. So that's why it's so important to give them things to do, but things that they're accustomed to. You know, if they were a baker, then this is the time to put some fruits and vegetables out. If dad was in electronics, this is maybe the time to get something, a simple piece of equipment, put it on the table, ask dad to fix it. You know, bring out some of his own magazines that he used to, Fish and Tackle or whatever it was, all right? This is the time to keep him engaged. This is also the time that maybe you want to look for some volunteers now while he can develop a relationship with him, that he can come in and do these things with him. So then it also gives the care partner a break, but it's also giving companionship for the individual with dementia. Oh, I'm sorry. Did I just do that?
You're good. You're
You can
good.
still see me?
Yep,
All right, because I can't see you, but that's all right. It'll probably come back.
you're here, I promise.
Okay. Okay, so another thing is the lighting in the house. The lighting in the house is very important. We had a case where the wife was becoming very suspicious of her husband. And there were nights too that she'd be sitting watching TV and she'd say, who are you? Where's my husband? And became suspicious, paranoid. She would call the police. One night she called the police. She said, there's a strange man in my house. So when we went in to do an assessment of the house did have very poor lighting, a lot of clutter. They were used to keeping the curtains closed because they felt that that kept the heat in so it could lower their gas bills or their oil bills. So what we did is we got the son to just redo the lighting, clean up the carpet, take away the clutter, and the woman had, and we did get her eyes checked. She had poor vision. So with all the darkness in the living room, she wasn't able to see her husband. So now the suspicion's gone, but that was a challenging behavior. Be careful with leaving the TV and the radio on all the time. You may think that it's companionship for them, but it isn't. It's noise. And especially now, I can't stress enough that it's very important not to keep the news on right now. Another cause of challenging behaviors is their clothes may not fit right. Maybe their clothes are too tight. Well, maybe they've got a bunion on their foot that you weren't aware of, that you just, kind of put into their shoe. Maybe their hair is too pulled back too tight. Things that we take for granted can cause agitation with a person. So ladies, for many of us who like the shiny floor, sometimes that shiny, clean floor looks nice and clean to you, but it could look like a sheet of ice, or it could look like standing water to someone with dementia. If there's mirrors throughout the house, Not all the time, but sometimes when they look at their own self. So now they think that there's somebody in the house, or sometimes they just get lost in the depth of the mirror. Let's see. I'll give you some scenarios of repetitive behaviors. One woman would complain because, especially because of COVID, she was doing her work at home. And when she was trying to get on the computer, Dad would sit on the couch. She put the TV on, but it wasn't a distraction for him. So we would sit at the end of the couch and he would tap his hands and tap his hands and tap his hands. So what did the daughter say? Dad, please stop tapping your hands. I'm on a Zoom meet. Please, Dad, stop tapping your hands. Does he understand what she's saying? Well, Dad was, I forget what he was, but what we did is she went and got his workbooks and his briefcase. So she put his briefcase on this table, opened it up, and there was some of his manuals that he had from work. So he looked at his manuals, he took notes while she was on her Zoom meet, and he felt he was part of the activity and he had something to do. Let's try, I love this scenario. We had a gentleman who every night, he was living in an assisted living, and they called us in because every night when everybody went to bed, this gentleman moved all the furniture, closed the doors, moved the furniture from one side of the room to the next side of the room. Every night. Then he slept all day. So they asked us to come in and see if they could get him on a change of a sleep cycle. It turns out when we did the life story with the family, Brenda, what do you think he did for a living?
He moved furniture.
Yep, he stripped and waxed floors in schools. When do you do that? You do that at night. You have to move all the desks to one side, strip and wax the floors, and move them back to the other side. And this is where the life story comes in. As soon as you understand why the behavior is happening, then you can adjust. So they just had clean floors. They let him clean the floors at night, and they let him sleep during the day. We had a gentleman who, and this is something I know right now, many adult day programs have not reopened, but I do know some of them are trying to get up and opening. So, and I do suggest to some of your care partners that this is definitely, it's a good means to help with the challenging behaviors and give respite for the family member. We had a gentleman who was a retired cop, and his family wanted him to come to the day program. And when he walked in, he looked at us and he goes, "Oh, no. He goes, I don't belong here. I don't know why you're here." And I looked at him and I said, "Oh my goodness, sir, I'm so sorry." I said, didn't your daughters explain? So he said, "Explain what? I'm not coming here." I said, "Well," I said, "I hope you don't mind." He said, "Very limited budget. So I was wondering if you could just volunteer here, and we're having a problem with people taking the wrong coats and people stealing. So we thought like maybe you could work undercover." Well, that man stayed with us for 5 years, watched the coat closet. Yeah. We gave him a purpose. We gave him a reason for getting up every morning. And then the behaviors at home changed. Let's see. It's hard, I know, but I tell the families, help minimize difficult behaviors is we have to slow down because they're going to react off of us. We have to slow down. Don't get frantic about the situation. If there's a behavior that's a new behavior, if it's not hurting anyone, and if it's not hurting the person, go with it. If they think it's Christmas and they're wrapping presents, just go with it. Remain calm. I know it's easier said than done. This is hard, but be kind. Sometimes in those situations, kindness is all they need. All they need is for you to take that time to say, "Gee, Dad, what's wrong?" And the one line that works all the time is the "I'm sorry." Take the blame, throw yourself under the bus. Say, "Dad, I'm so sorry. I didn't mean to hurt your feelings." And it's very important also is if you don't understand what your care partner, your loved one is asking, don't pretend that you know what they're saying, because they know when you know what they're saying. Don't laugh. Sometimes you want to laugh, you just want to change the mood. They'll feel like that you're laughing at them. And what else? I think that's about it. Just focus on what's going on in their mind rather than their behavior. Just think of their behavior as they're trying to get a message across, and it's our job to figure it out.
Well, let me ask you something, Donna. Excuse me. All those wonderful tips that you just said, what happens if you know their life story, you know their background, You've tried some different things to do. Are there ways that do not include medications, that are non-pharmacological, things that they can do perhaps to alter their behavior, change it? Excuse me.
There's a few. One of my favorites is, I think of aromatherapy. I think of it as, what does the person like? So if this person loves sweets, suggestion is, if you have a what's the slow cooker? Crock pots, right? Steam apples. Steam apples in the beginning of the day, pour some cinnamon on and let it stew and let it cook throughout the day. And then you have something for dessert at the end of the day. But that smell has a calming effect. And if somebody's also having difficulties eating or not enjoying their meals, that will increase their appetite. I do like pet therapy, really, really works. So if you have a pet, take advantage of the situation. Take them out for a walk. Music therapy, music. Know what music that your loved one listened to over the course of the years. Sometimes what they like today, they don't like now, but they'll remember when you the 50s and the 60s. And that's why it's also important to know what they like and what they don't like, because you can use it as a distraction. So when dad is saying to you, what time is it? And you say, Dad, it's 11 o'clock. Yeah, okay, 5 minutes later. So what time is it? Now remember, their short-term memory is impaired. They don't remember that you told them it's 11 o'clock. So by the third time, if they don't get that you say, Dad, I said to you, it's 11 o'clock. That's when you say, oh my goodness, Dad, did I forget an appointment? Oh my, let's go check the calendar. And you know what? I think it's getting near lunchtime, even if it's not near lunchtime. If you know that Dad loves his fruit right before his lunch, that's the time. You know what, Dad, let's go get the lunch. Let's go get some fruit. Distraction techniques. And I also suggest when you're doing activities of daily living, when you're getting, dressed in the morning or shaving, use them as an activity. Don't rush through them, because when you're rushing through them, that's going to increase their anxiety. And then this is when they lash out, and this is when you have another challenging behavior.
Okay. Now, I'm sorry, Donna.
Yeah, I just wanted to give another scenario that we just worked with not too long ago, because I know sometimes throughout the disease process, they don't want to eat. And you put the food in front of them and you say, come on, Mom, it's time to eat. Have a little something. I won't go through all the techniques of, giving the food on a smaller plate, making the plate colorful and attractive, but sometimes think about why they're not eating. We had a woman in one of these, the assisted living's dementia care, and they just put the food in front of her. She looked at it, she shook her head, and now granted, I'm sure the food didn't look as hers looked, over the course of her lifetime. But when they looked at her life story, she loved to cook. She cooked for everybody. She made meals for the neighborhood. So how we got her to eat, we sat down and we said, Rita, my goodness, could you taste this for me? Because I'm not sure I put enough seasoning in it. Do you think it needs a little bit more salt or a little less oregano? So she tasted the food.
That's great.
I wouldn't have known to do that if I didn't know her life story.
Right. That's great. Great tips. Now, we talk about all those different tips, but Dr. Bell, correct me if I'm wrong. There are times when you do have to use some medications. Pharmacologically, there are times when it does come into the picture. Do you want to talk a little bit about that?
Yeah, let me take a moment or two to just discuss that. These non-pharmacological tips that you just heard from Donna are extremely important, and they're probably the first thing that you need to learn to redirect things. Medication to deal with these behaviors should be, second line or our last resort, because we want people to be on as little medication as possible. So depending on what symptom it cannot be managed by redirecting or other types of therapy. If someone is over anxious, has a lot of anxiety, then you'll find that your clinicians are going to use antidepressants or the atypical antidepressants that have more of an anti-anxiety component to them to help with those behaviors. And they use them in a very low dose. If we're treating hallucinations or delusions that can't be managed by being redirected, then doctors try to use the lowest dose of some of the antipsychotics, not in the large doses that are used in people who have schizophrenia and other mental illnesses. We use these in very tiny doses so that we don't have to worry as much about the side effects. Those are the types of things that we try to do. I want to give people an example of what would cause someone to be more confused, or how you could feel that you're in the shoes of someone with one of these disorders. You know, you probably, most of you in the audience have traveled, stayed in a hotel, and awakened in the middle of the night and been unsure for a few seconds of where you are. If you have one of these dementias that we've discussed, a lot of times you aren't sure where you are all the time. So I want you to understand what a disorienting experience that is and how it can make these behaviors blossom.
Wow. That's really an interesting little tidbit, because I think that happens to everyone, right?
It does.
You wake up and you say, and you look around, where am I? Absolutely. I think all of the things that you've said have been wonderful, because you're not only giving people scenarios, real scenarios of, I think to me, one of the most important nuggets is to get to know the person, to get their life story, because from that life story, you can glean some information that may help you understand the behaviors better.
Right.
What I'd like to do now, thank you, Dr. Bell and Donna. I'd like to open it up to the audience if they've got questions, specific questions about your loved ones. So please, folks, feel free. There is a Q&A box either on the top or the bottom of your screen, or the chat box. Please feel free to type in your questions. And I see we already have a question. My uncle has been diagnosed with Lewy body dementia and often has hallucinations. What do I do when he thinks there's a strange woman in bed with him and he gets scared and agitated?
Well, I can
Yes,
start.
Dr. Bell?
That's the time to turn on the light. Make sure that the person can see, that uncle can see who's in the room with him. It's also important to have photographs of your spouse around, maybe even the wedding photo, so you can point out who this person is. Now, you guys have to remember that as your short-term memory becomes less and less, meaning more impaired, the memories that are most vivid are the ones from a long time ago. And sometimes when someone is looking at their spouse and saying, that's not my wife or my husband, it's because they're remembering that younger version of the person. So point out the pictures and then show in the pictures that they've both aged. And that can be helpful.
Interesting. You're right. They're thinking about when they got married at 19 years old. Great.
And at that point, sometimes they just need that hug then, that the way you used to hug them, because the emotional part of the brain gets damaged later in the process. So, hug them the way you would have hugged them 20 years ago.
It's a good tip. We have another question. My mom has dementia and becomes very fearful and suspicious of going to see the doctor. These appointments are necessary due to several ailments. I try to reassure her and tell her many times, but she forgets and keeps asking where are we going and why. But she gets very scared and paranoid. What do I do to reassure her everything will be okay?
I don't know if this person is giving information about the appointment beforehand. I usually recommend that it's not advisable to tell her too soon, too far in advance, because first of all, she's forgetting it, so that's causing anxiety. And if she's having anxiety, then you're just increasing it because now she knows she has to go to the doctor. First of all, that any questions that she has with the doctor, and most doctors, Dr. Bell, I'm sure they do this, email the doctor beforehand, email the office manager or the nurse there, all the questions and the concerns and the reason for your visit. So number one, you're not having that conversation in front of mom.
Right.
Also important that if she gets dressed and she's to go, we're going out for lunch today. And then when you get in the car, say, oh my goodness, I forgot. We just have to make one quick trip to the doctor. Just it's on our way to having lunch. So she's in the car. This is when you kind of hold her hand. And then if she gets upset with you, say, I'm so sorry. I totally forgot. The doctor called this morning and changed the appointment. We weren't supposed to go until next week, but he called this morning and I just forgot and I rushed. Take the blame, put it all on yourself.
I like that. I like that. Yeah.
And less conversation while they're in there.
Okay. We have another question. I believe, Dr. Bell, this is for you. Are there any medications that can slow down the progression of dementia?
Well, that's a good question. We have medications to treat Alzheimer's disease. We don't have special medications to treat frontotemporal dementia or really vascular dementia. Vascular dementia is the medications we use are to prevent you from having future strokes. Okay, so that's how you prevent that from getting worse. With Alzheimer's disease, we use the medications that are approved to treat in the earliest stages to see if we can slow down progression, but they are not, no one can actually tell you that they truly slow progression because that's not how the initial trials were designed to measure whether those drugs worked. Now, probably many of you are aware that there was a new medication that was approved last summer for Alzheimer's disease and very mild cognitive impairment. That medication is quite controversial. It is designed to be a disease modifier, but the jury is still out on how useful that is going to be in altering the course. So we will see when Medicare makes its determination in April and whether additional agents get approved later this year, whether they have better efficacy in slowing the progression of the disease.
Great, thanks. Okay, we have another question. I work in a dementia long-term care facility and have been told to allow seniors to have their own sleep patterns. For example, there's a male who sleeps in the day and is awake at night. Is this a manifestation of his dementia or considered normal for him? We have minimal information about him from his family.
Well, as a memory care director, I believe it's very important. That's the reason that one of the reasons that you encourage families to go to a memory care is so they can continue whatever their lifestyle was. It's not about getting everybody to bed at 7 or 8 o'clock at night and everybody up at 9 o'clock in the morning. And I had residents that I would allow come to the breakfast table in their bathrobe because that's what they did when they retired, or people like at 5 a.m. and like to have a cup of tea and read the paper and then got dressed for breakfast. That's what they were used to doing. That's fine. Yes, it is important to figure out, did he sleep, during the day and work at night? That's really important. And if that was the case, then I think, yes, in memory care, he should be allowed that. And in memory care, technically, there should be activities for that person at night that's up in the night.
Right. Good point.
Now, I just want to say, though, that if they're not in memory care and they're in the community dwelling in their own home, that doesn't always work for the caregiver
Correct.
who's caring for them. So it's
Very true.
You have to try and shift their sleep-wake cycle to align a little better with the people they're living with, because that really only works in memory care where you have someone who can be awake all day, all night with you, just making sure things don't go wrong. So that's something to think about.
No, absolutely. Thank you.
Absolutely. Okay, we have time for one more question. Let's see. I have tried many strategies to manage my aunt, but nothing seems to work with her dementia and screaming. At what point would I turn to help from one of you? That's a really good question.
I guess now.
That's what I was going to say.
Now, no time like the present. Give us a call. That's a question that you can't just answer. I need to get some information. I need to know what her history is. When is she screaming? What time of the day? She could be a screamer like I am, and it's my, I think that's normal for me. Oh, mom's at it again.
Are you screaming when you're driving 80 miles an hour down the road, right?
No,
Because
I'm
you sing.
singing then. I'm singing then.
Oh, okay. Okay, folks. It's right about time that we're going to have to wrap up. We have a comment. This was a great presentation. Thank you, Brenda, Donna, and Dr. Bell. Thank you, Mark. Thank you. Thank you.
Maybe
So I
next
want to
time.
thank our speakers for this evening, Donna and Dr. Bell. I also want to thank my colleague, Gina Forgione. Gina is in the background working all her magic. So thank you, Gina. And folks, if you'd like to learn more about the Kensington, please you can call us 914-390-0080, or please go to our website, www.thekensingtonwhiteplains.com. And if you all stay put for a moment, there will be an end slide coming up on the screen that will contain information if you'd like to get in touch with Donna or Dr. Bell. And also in about 2 to 3 days, the Kensington will send out an email that will also contain their contact information. So for my person that asked that question, when should you get in touch with them? Now is the time. So thank you all. Thank you so much for joining us. I hope you all have a wonderful evening. Thank you.
Thank you, Brenda. Thank you, Dr. Bell.
Thank both of you. I think
Thank
this
you.
was a great program.
Take care of that tooth.